We've started a recording. This webinar is on, the Zoom is on a webinar function, which means that your cameras and microphones are automatically switched off. However, we do have the chat function and a Q&A option at the bottom as well for you to write your questions in, as we'd still love to hear from you. If you have any questions throughout the event for our panelists, please write them in the Q&A box. And once we reach the question and answer section, I'll make sure to relay those to the panelists. So I hope you enjoy this event. We're really excited to be part of this interesting conversation. How this event is going to run is that we're going to have each of our panelists do a short presentation each. After that, we'll enter into a panel discussion chaired by Helen Hester, and then we will have a Q&A afterwards with your questions. So hopefully it will still be really interactive and we'll be able to get a conversation going. So without further ado, I'd like to introduce Helen, who is a Professor of Gender, Technology and Cultural Politics at the University of West London. Her research interests include techno-feminism, social reproduction and theories of work. And she also leads the Feminist Futures programme for the think tank Autonomy. So I will just make you spotlight, and over to you, Helen.
Thank you so much, Erica, and thank you all so much for being here today, our audience members and our panelists. It's a real privilege to have you all here. So today's webinar is on technologies of care. I'm sure you're aware of that, but just in case. So I'm joined today by 5 people who work to different extents and in quite different ways at this kind of interface between tech and care. So our speakers are, in alphabetical order, Emma Dowling, a sociologist and political economist at the University of Vienna. Her research interests include feminist political economy, work, and emotions and social change. And she is the author of The Care Crisis, What Caused It and How Can We End It, which came out with Verso this year. I'm joined by Mavis Machiroy, a senior researcher at the Ada Lovelace Institute, focusing on projects at the intersection of data-driven systems and digital technologies and their wider health and social impacts. Mavis obtained her PhD in health studies from King's College London and is a midwife by background. She's interested in issues of inequalities and power dynamics that impact people's experiences of health and care, and considers ways to ensure marginalised voices are heard. We have Dennis Olsen, who is Senior Lecturer for Advertising and Branding at the University of West London, whose research interests revolve around ageing societies, particularly the study of stereotypes in the media and shifting consumer behaviours. And then we're joined by Stephanie Sherman, who is a London-based director, producer, writer, and strategist working across design, urbanism, technology, and culture. She teaches city design at the Royal College of Art. And finally, Julian Saravo, an architect and urbanist from Rome, who heads a programme of research for the think tank Autonomy. Julian's work focuses on ageing populations and the future of care, logistics, and workspace. And he has spent time both in commercial and research-based architectural practices. So in the course of today's session, our speakers will draw on their own work to consider issues around how technologies of care are developing, the risks and the opportunities that they might present for carers, their link to the quality of care, and which areas should be prioritised for academic research. And this is perhaps, I think, the key question that's animating this event. What and how can academic and policy-facing research contribute to efforts to build better care systems? Systems which involve people, technologies, economic and regulatory frameworks, organisations, places, infrastructures, and all kinds of other forces. After our sort of initial presentation, we're going to engage in a panel discussion before finishing with a Q&A. So as our speakers are talking, maybe have a think if you've got any pressing questions, and feel free to drop those in the chat. And we're going to kick off with a presentation from Emma. Emma, I invite you to take it away.
Great, thank you very much. And thanks very much for inviting me to be part of today's panel. I'm in Vienna and it's incredibly hot here, so if I look a bit flustered, that's why. But it is an absolute pleasure to be with you and to speak about my research on care and technology. And I'd say maybe to kick us off that it's almost a truism to say it, but technology doesn't develop in a vacuum. Instead, decisions are made about the problems technologies are meant to address and how these problems are to be addressed. And indeed, of course, who fits the bill. And I'd say it matters who makes the decisions, who deploys the technology and to what end. It matters who the programmers and engineers are and what assumptions they hold. It matters what investment decisions, forms of ownership and business models inform the development and use of technology. And at present, I would posit that the majority of technologies, and maybe this is controversial, but that they are overwhelmingly driven by two key goals that are directly linked to the relationship between production and reproduction in capitalist economies. The first of these is reducing the cost of care. Of course, the immediate question we could ask is for whom? But I'd say reducing the cost of care, particularly for governments and for a lot of the time also for organizations involved in providing care. Second thing would be to free up capacity so that people can be put to work, either put to more work or also freeing up the capacities of those who might otherwise be involved with caring for loved ones and freeing up their time to participate in the labour market. And I would argue those are two quite central driving goals at the moment in the development of technologies of care. And I want to illustrate this point with regard to a couple of, or a few examples with regard to information and communication technologies and also assistive technologies in the area of care. And I'm taking quite a broad view on what I mean by care here. I think we could think quite concretely about how we define care as the sort of technologies that are immediately, sorry, my phone is ringing there. I'm very sorry about that. The immediate involvement in care in terms of actually assisting the process of caring for someone, but also sort of technologies involved more generally with care infrastructures and providing care infrastructure. So I'm taking quite a broad view on how we might define care. Now, one example, I think of the ways in which cost saving at the expense of workers actually is informing tech developments in care is with regard to things like electronic monitoring of home care workers on the basis of contact time, so the duration of a visit in someone's home. And here, certainly in the UK at the moment, predominant is still the in the context of local councils, the idea of time and task commissioning. So contact time here becomes the metric for commissioning home care services. So it's not so much a set price for a visit, but actually the time and task involved, and particularly the contact time, how much time a home care worker might spend in someone's home. Now, when electronic monitoring is involved here, what tends to happen is that the time that somebody spends in someone's home becomes sort of a way that somebody will clock in and clock out of a system. And this person is usually under considerable time pressure because of tight budgets and because they have to get quite a lot done in very little time. What electronic monitoring does here often is it's a sort of conduit towards a situation where time pressures can become more intense, and where if somebody only has like 15 minutes to perform quite a lot of duties, they might have to, say, cut out what is not the actual immediately really necessary things of care, the emotional, relational, affective aspects of care work, or they might have to stay beyond the allotted time, say if something untoward arises, or even just to have a chat with somebody who might otherwise be alone all day. And so here, I think electronic monitoring something is that it inserts itself into a system where cost saving happens at the expense of workers, but also sort of assists with redefining what constitutes actual care and what are sort of the extras, like the more emotional, affective dimensions for which there might not be very much time. Another example where I think we see problems around private wealth extraction and privatization are platforms like, for example, Babylon Health, that use data-driven tools for the self-management of conditions that include health, mood, and activity monitoring, or symptom checking, or online GP consultations. Artificial intelligence, machine learning are deployed to refine the interpretation of symptom descriptions by users with a view to better diagnostics and advice. And the aim here is to increase user self-management of healthcare needs and decrease the need for interaction with medical professionals. Now, on the one hand, users can sign up privately to pay a subscription fee, but there's also a version of the service that's available in the UK via the NHS under the name GP at Hand. And this purports to provide a solution to the ongoing crisis in primary healthcare for two reasons. First of all, the aim is to enable patients to avoid long waiting times and have a video consultation with a doctor within quite a short period of time. But also, the app is supposed to save the NHS money by increasing the occasions when users can self-manage their health without needing to be seen by a doctor. One of the things that seems to be happening here is that this service is particularly taken up by younger, fitter, or sort of relatively fit, affluent parts of the population. Older people, people with more complex health needs, those with caring responsibilities are less likely to use it. But of course, people with fewer healthcare needs are also less costly to treat. And I want to raise the sort of issue here of the broader context and political economy within which these solutions, these tech solutions are offered, namely here where the younger, healthier patients are sort of being taken out of the GP practices, and those with more complex health needs are left behind, meaning that resources are sort of taken out, but the GP practices operate as a kind of safety net because Babylon users have the right to switch back whenever they want to or need to. I think we had to sort of step back for a moment and think, how are GP practices currently funded? They're funded through weighted payments for each patient. And this weighting takes into consideration the healthcare needs of a particular population a practice serves, including factors such as age, gender, and socioeconomic situation. But risk is pooled because those who are younger and fitter require less attention and therefore fewer resources. So the basic principle of risk pooling is that our health needs vary over the course of a lifetime. And emphasizing individual freedom and the right to choice, Babylon's business model effectively undermines the principle and the material base of collective solidarity and risk pooling that are fundamental to public health care. And so the promise is that this system helps to save money for the public purse, but also huge financial returns are expected. The startup was valued at $2 billion after raising $550 million from international investors in 2019. So we could also pose the question of what happens with those savings. Are they then in turn actually being privatized? Another area I want to briefly mention are new business models for individualized care solutions that rely on unpaid or underpaid precarious labor. So for example, platforms like care.com that offer individualized solutions to the care crisis for families, promising even to empower women by enabling them to participate in the labor market because someone else will do the caring for them for less money than what they will be able to earn by going out to work. Care.com charges private households a subscription fee to connect with care workers offering childcare, elder care services and similar on an hourly basis. Now, hired as independent contractors, the workers offering their services are part of a growing precarious workforce in the gig economy. And I think there are other examples here also of services where machine learning is also used or developed by drawing on sort of volunteer labor, like something like Be My Eyes, a platform that enables volunteers to assist visually impaired people with a short online video call, which on the one hand sounds like this is an interesting and useful development, but at the same time sort of within the kind of business model which is orientated towards developing commercial AI products, we might raise questions of access and also questions around privacy, data collection, etc. And I want to end on the issue also of age tech, and that's the term given to the growing range of innovations in remote monitoring and AI machine learning for older people. So sort of technology that can be used around the house, assistive technologies like sensors to detect and alert in the case of a fall or accident, or if water is left running, and all sorts of kind of household appliances that can also be connected up to people who are either loved ones who are remote, or also to agencies that might be involved with caring. And I think one of the things that is important to think through here is that in the realm of care, enabling those who need care to live independently through assistive technology is about enhancing human freedom, but it's also about reducing the need for human labor, whether this is in the form of a paid care worker or in the form of relatives, friends, neighbors, or volunteers whose time is thereby freed up to do other things, and not least be available for the labor market. I think also a lot of assistive technologies, or particularly large project assistive technologies, can also rely quite heavily on the need for public funding, because they might actually not be commercially viable or interesting for, say, venture capital. And I think here there was another issue around how technologies, the development of technology, and we've seen this also in debates at the moment around vaccines, rely on public funding, but actually then profits are privatized. So always coming back, for me, the issue is to this political economy, but also, if I may, just to end, say that technological developments throw up questions about the meaning of care, especially where machines assist with everyday tasks that can be translated into repetitive, routinized, and standardized procedures, as opposed to the more complex tasks of care work. And so when a machine takes on a task, it doesn't simply do the same thing that a human did beforehand. Instead, the nature and even the meaning of tasks are transformed, while new tasks are also created in the process. And here I think we need to have an attention to the ways in which sort of ideas about robots replacing care workers often rely on a conception of care that is encapsulated in precisely the kinds of reductionist notions of actual care that are behind the current political economy, where we are not actually attributing enough resources to care. So it's sort of tight budgets, cost saving. Actual care is merely assistance with physical tasks, but actually this sort of loses sight of a more holistic understanding of care, which requires not just help with physical tasks, but a whole array of skills that care workers require, that are often also more complex than those for which technologies can be used. And at the same time, I think, we have to think how care work is a relational, effective kind of personal service that requires quite an intensive deployment of mind and body. It's also being in the presence of the person who is being cared for. And I think this is sort of generally an issue we need to be attentive to, that a lot of the time the kind of rationalizations that we see within the area of care work are kind of pseudo rationalizations, sort of redrawing the boundary between what counts as work, what counts as not as work, what counts as sort of professional, what counts as unpaid work. And so situating our debate within these questions of political economy, I think, raises issues for us around how our technologies, what kinds of technologies are being developed, how are they being developed, and what are the political questions that come with that. And I'll stop there. Thanks very much.
Thank you so much, Emma. What a great way to get started, delving straight in with these sort of structural questions, these political and economic questions, and ethical questions as well. A very interesting way to kick off this discussion. Thank you. Okay, so our second speaker is Dennis. Dennis, welcome.
Thank you very much. I just quickly share my screen. 1 second. There you go. I hope you can all see that now. So let me just put my... So in late May this year, the BBC published a feature entitled, "Could My Mom's Toaster Help Me Care for Her?" In it, an app service for non-intrusive load monitoring was discussed that allows relatives to keep an eye on elderly or vulnerable people living alone by checking in on their electricity usage. This and similar emerging technologies of late have drawn distinctively on people's everyday life and ordinary tasks to identify opportunities for technological innovations. The aim is to transform lived experiences by turning the everyday into critical knowledge. From an academic point of view, the importance of the everyday has been emphasized for quite some time. Although many people share similar daily routines, each person ascribes their patterns of chores and activities unique meanings and values, turning one's everyday throughout a lifetime into a uniquely personal experience that shapes one's identity. When it comes to technology adoption, so how quickly we integrate new technologies in our lives, technological innovations rooted in a person's ordinary surrounding, inspired by the personalized experiences, face less resistance and are more quickly adopted by a larger number of people. The widespread acceptance of the smartphone is a good example here. Its adoption took only 1/3 of the time that it took the cell phone, 2 compared to 7 years, to reach a critical mass of 50% of the population in the UK. This is because once people got used to the idea of carrying around an additional device on them 24/7 and incorporated this into their daily routines, switching to a more useful device wasn't much of a leap. This is important to keep in mind because how useful really is even a revolutionary new technology if it ends up not being used? The concept of everydayness has been fertile ground for the search of technological innovations that make our life easier. And it can also be a very fertile ground for transforming adult social care. An initiative in the context of technologies of care that this seminar is about, that I'd like to talk more about today, is the application ad memoir developed by the History of Advertising Trust. The app launched in 2019 and is an advertising-based digital reminiscence and activity resource designed to help carers to improve the quality of life for older people living in care. The History of Advertising Trust is a Norfolk-based educational charity and the largest archive of advertising in the world. The Ad Memoir app provides access to reels of some of the UK's best-loved vintage adverts from the 1950s and 60s. Some of Britain's biggest advertisers have agreed to allow their vintage commercials and print ads to be used as part of the initiative. The app also features catchy jingles and memorable slogans and is complemented with activity resources such as puzzles and quizzes, compiled in consultation with the National Activity Providers Association. One of the key features are the on-screen conversation prompts based on the ads to engage residents and assist care staff to form meaningful connections. Advertisements are very powerful when it comes to sparking conversations. Their continuous repetition at the time when they're aired and the combination of short stories, catchy images, and music leave traces in our memories. I'm sure all of us can probably recall some of our favorite commercials from our childhoods in an instant. Adverts are shared knowledge within society. They're part of a society's zeitgeist and thus make for a reliable stimulus. Research by Laying Bison and Age UK show that of the 500,000 older care home residents in the UK at the moment, many suffer from depression and feeling disconnected from others, which is compounded by high staff turnover amongst their carers. Care staff is often strained for time. It can be difficult for them to always form meaningful connections, which are so vital for a person's mental well-being. Ad Memoir cleverly uses people's past everyday experiences to access a person's memory and create connections with people around them in the present. It aims to provide a tool for carers that reliably prompts conversations that are meaningful to the person in care and provide a structured and efficient way for the carer to get to know a person even when pushed for time. Let me show you a short video that includes some reactions from residents in one of the trial care homes.
Ad Memoir is a digital reminiscence and activity resource for older people's care organisations. And the app is filled with fantastic 1950s and 1960s advertising from the collections at the History of Advertising Trust, the largest archive of advertising in the world. The app aims to help improve the quality of life for older people and those living with dementia. We hope that Ad Memoir helps to spark happy memories that they can discuss with carers and family members and also each other as well.
I think short-term memory in older people is something that comes quite difficult, but distant memories come back a lot more readily. And I think especially with the jingles that we had on, music really triggers those kind of responses and brings back good memories for people.
A reminiscence session with Ad Memoir will essentially involve TV commercials on screen and then also prompts for conversation starters. And then you would move on to a hard copy quiz, which also contains fantastic vintage advertising images from Hat's collections as well. Ad Memoir is extremely versatile. It can be used one-to-one on a tablet or smartphone, but it also can be used for larger group activities through a TV screen or also via a laptop and an HDMI cable. The app is designed to be as easy to use as possible.
It's very easy because you've got all the prompts as well, which helps us to ask the right questions. It's an extra bonus having that there. You go home at the end of the day feeling you've done a good job and it's been worthwhile.
I think the customers are getting a real sense of achievement from what they're talking about this morning as well. It instigated conversation at the table we were overhearing. And you know, for a lot of people they're very isolated in the homes, and for here to come in somewhere like this and do an interactive game, you know, especially with adverts, it prompted a lot of interaction, smiles, singing.
And I think it's probably broadened their line of thought as to what kind of questions they can ask and how things lead on. Because it's amazing. It can bring up all sorts of memories about all sorts of different things, which is fantastic.
I think Ad Memoir is very important for keeping people's minds active. A wonderful way of getting people to talk about their past.
Yes, it does take your mind back, doesn't it? You think, oh wow, gosh, was that long ago? That was very nice, I've enjoyed it.
It's an opening up of all sorts of avenues. I just let myself go. Why not?
Fantastic.
Fantastic.
The mood in the room today was wonderful to see. Lots of people joining in, singing along to the songs, tapping toes, clapping hands, general smiles and laughter.
I think they're feeling quite elated that they've had something different to do and quite positive.
Ad Memoir has really allowed us, as the History of Advertising Trust, to use our archive to help society in a much bigger way than before. The archive has always been great for education, but now we can realise the social benefits of the material in it as well.
Okay, let me just stop this. So far the app has been tested on a small scale in 2 care home settings in Norfolk and Southwest London, as well as in an acute hospital setting in Norfolk and Norwich Hospital, where it was used by the dementia support team. Therefore, a proof of concept that the idea of the app can be beneficial for patients already exists. The results from the pilot study of the acute hospital setting were presented last November at UK's Dementia Congress. Insight included that the app was able to stimulate fun and laughter and help workers make an instant connection, distracting patients, putting them at ease, and stimulating conversations and memories of fun times. The research team also reported that showing the adverts before mealtimes could help stimulate a patient's appetite and make patients feel more empowered. These are undoubtedly positive findings, but they are not the full picture that is needed to scale this up and really introduce it on a wider basis. What is still missing, and what I believe is crucial for any successful technology of care, is to explore the perceived usefulness for carers and their day-to-day caregiving practice. Perceived usefulness is crucial for technology adoption. This requires an open and honest conversation with care staff to explore the full potential and drawbacks of this application. As I said before, the idea behind the app is that it supports a structured and time-efficient way to get to know the person in care. So questions that are still unanswered include how exactly the app can be used on a day-to-day basis from a carer's perspective. Are there certain scenarios that work well and are easy to implement in a carer's working routine? Is this just another gadget that is piled on top of a carer's already full plate? Or does this actually make a difference for the quality of care that they can provide under the time restraints they're working with? And how can this be turned into a tool that eases their labor and make a difference for their working life? What support would they want from the app developers, as well as from the care providers? The University of West London and the History of Advertising Trusts are currently in a planning stage of a study addressing these and similar questions. I cannot stress enough how important it is to investigate the voices of all stakeholders to make a technology of care truly successful. AdMemoir is a promising technology and technological innovation inspired by the everyday of its users, enhancing human interaction in a care setting. Thank you very much for listening.
Thank you, Dennis. Thank you. That's very interesting to go from sort of the broader discussion of the sort of the structural factors in the political economy with Emma's talk to grounding it in a specific case study. And I think it's really crucial that we think about these sort of specific cases so that technology doesn't become some kind of metaphysically inflated phantom in these discussions about technologies of care. We understand that we need to get into the sort of the granular detail to understand these things and how they work and their implications for those delivering and in receipt of care. So thank you very much. Okay, we now have two speakers. We have Julian and Stephanie. So I invite you to take the floor.
Thank you, Helen. Thank you, Dennis and Emma, for your talks. Those were absolutely fantastic. So I'm Stephanie and I are both in the urban team at Autonomy, and I'm going to start by talking about actually a spatial infrastructure that we've been developing at Autonomy. And we're going to ask sort of what questions this raises for issues around technology and care. So the infrastructure is called long-term care centers, and it's really intended as a way to explore futures around neighborhood-based and cooperative models of care. And really, in its essence, if we had to sort of answer, what is it or what does it want to be, it would really like to be the first point of contact for any care-related needs in a neighborhood. It should be open to all. It should be free at the point of use. And it should be really, let's say, rolled out in a capillary fashion, sort of in its ultimate form. So I'm going to take you through some of the principles that have guided the design and development of this concept of long-term care centers. And the first one is that this is a space for the ongoing maintenance and management of the body. And that means for us moving away from a framing of the processes of aging through illness and its association with death. So this also means that we are moving beyond a healthy sick binary when talking about aging. Beyond a young old binary as well, because we're talking about long-term care and the maintenance of the body without defining an age or an age group to which this infrastructure necessarily refers. Although obviously it does sort of address the needs of aging adults regardless. And also the infrastructure should really recognize the reciprocity of care relations, and so moving beyond this binary between carers and care recipients. All in all, it really wants to be this third space of care between the home, which we really think is a space that should be demedicalized, and the hospital, which we believe should be a space dedicated to the treatment of acute illness rather than of the ongoing management of the processes of aging. And the way we've designed, let's say, the programmatic strategy of long-term care centers is really trying to combine support for care workers with services for community health. And I guess that is one of the axes along which we've organized this, and the other axis goes from a spontaneous use of different spaces that you might just sort of walk into, both as a care worker and as a community member, to more sort of structured uses of rooms and hardware. So this is sort of on one end of the axis, on the sort of community health end of the axis. You might find a sauna or a community kitchen, while on the other end, you might find services for care workers working in the neighborhood, from locker rooms to napping areas and other amenities. So what are the specific aims here that we're going for in thinking about these centers? One of them is to give visibility and recognition to all forms of care work and types of care worker. And this is something that isn't necessarily discussed so much outside of the architectural and urban fields, and not so much in the urban field and architecture field themselves, which is really about architecture as a communication device, to really say something about what importance do we give to different subjects in the city, who is visible and through what architecture. So just to get a bit more specific about what we mean with these multiple senses of care work, this space might respond to informal paid care workers, unpaid family carers, employees of the NHS and maybe council-run social care, volunteers, as well as all the shadow work that goes on with self-care and with, but also just managing sort of the bureaucracy of our own care. Another one of the aims is to expand the sphere of autonomy, both for care workers and communities. So this means also sort of with spaces of collective deliberation. And I guess this is both an aim and a strategy in a way, which is to care to practical short-term needs first. So you saw that, for example, with the locker rooms and things like this, but actually to start preparing for the expansion of cooperative care at scale, right? So start with the practical needs, but actually sort of build a longer term strategy that can be with rooms and opportunities for training, as well as direct support into sort of getting into sort of better forms of employment when it comes to care. And this work has actually picked up a little bit of interest in the media as well. And it's always important to know sort of which bits of it sort of capture people's attention and capture the media's attention as well. Steph.
Yeah, so thanks, Julian. So one of the questions that we've been asking now, building on this work of long-term care centers, is how can we actually think about these collective spaces as a technology, and thinking about also the opportunities that they bring to integrating technologies into a more socialized framework. So of course, our question is, what would a technology strategy for LTCCs look like? And this is we're at the very beginning and early stages of asking these questions, so we might have more questions than answers. But our thinking starts from the idea that care work and those in need of care are often at the forefront of technological augmentation, and thinking about that as a bit of an opportunity, as well as something to be critical and conscientious of. So things like assisted walking systems that help carers and care workers augment the body and support their work in performing the everyday labor of care that's necessary to do the various things they need to do. Those of you who are familiar with this is kind of a legendary design example with the OXO designed kitchenware working with arthritis patients with a healthy grip handle that turned out to be a thing that worked better for everyone. And so this idea of the exceptional circumstances or more non-normative subjects, helping us design more universal frameworks and tools. So one of the things we've been thinking a lot about is how hardware and software that's currently developed for care, of course, addresses issues on an individual basis and tend to focus on individual and the personal health rather than community or collective health. So the body of care workers or the space of care itself, and that collective group being as important as the individual needs that those who need care have, and those who give care have as well. Another familiar example from the field, Paro, the robotic seal in Japan, with its history of a lack of caregivers because of its mostly because of its immigration policy, but also because of its aging population, and a bit of a contentious tool or device for mediation that was very popular with many of the people who received it or were part of this experiment, but also questions around how interfacing with a tool or an object, is this ethical for subjects? How does this augment? How can mediation happen? So what we're thinking about now is, of course, how can we use LTCCs in this strategy of thinking about these care centers to augment the social capacity of the technology, and what can they tell us about the social capacity of technologies in general? One of the kind of more traditional frameworks we might think about it is something like this, an app or a network that would interlink the many needs of care and care workers through cloud-based or network solutions. We can think about those both as a more capitalist-driven platform, but also as socially driven platforms that connect needs throughout the community vis-a-vis this kind of software interface, let's say. But in this work of thinking about actually physical spaces and architectural spaces, we're also excited to think about what it means for potentially collective interfaces. So how the integration of technologies throughout these environments in the collective and social spaces might offer new kinds of ways to think about the technologies that are possible for collectivity and sociality in general. And of course, what is important to remember that the needs and desires of collective care would be quantitatively and qualitatively different, and that this is an area where we should probe and explore. And we're excited to think about how these forms of mediation, these architectures and these spaces as technologies would enable forms of interdependency and sort of augment that and support that, rather than kind of denying it or assuming that the individual relationship between the cared for and the caregivers is where caring stops. And so just a diagram of some of the axes that we're thinking about that are intersecting along this research.
Thank you. And again, I think that sort of returns to the point that Emma started with about the need to understand that sort of technology is as social as society is technical. I think that's you make that point very clearly throughout that presentation. Thank you very much. Okay, so at this point I will turn to our final speaker, Mavis Maturori. Mavis, please take the floor. Welcome. Thank you.
Thank you, and thanks to the previous speakers. It's been really fascinating listening to all your perspectives. What I'm going to do is just spend the next few minutes, I guess, looking at technology mostly from the perspective of a clinician, I guess, having worked as a midwife for over 10 years, and thinking about some of the concerns that have been coming up in my current work, which looks at, as was mentioned earlier, the impact of technologies and data-driven systems on society. So I don't believe also that we can talk about technology without talking about the data that is used to build it, since these are intertwined. But we can look at technology as potentially the physical objects that are enabled or changed by digitization and the ability to then network the insights that emerge from that. So as a clinician, I couldn't talk about technology without thinking about what a benign technology or a mundane technology might look like. So we take the example of a blood pressure monitor, for instance. That technology alone, when used to assess the condition of someone's health, can change what the health practitioner and patient relationship is like. So a blood pressure monitoring chart, where we then can become an early warning scorecard, which helps the practitioner decide what sort of care to provide, because they're then making decisions around the condition of the patient in front of them. When we start to pull those individual data points of blood pressures, we can start to see trends, and then we infer health status from those trends potentially. So the knowledge that emerges from that and the care that we can provide will only be as good as the data that's collected or that's available to us. So in the same way, we can think about tech, and we decide what information to collect and what to act on. And in this case, we then think about issues beyond the physical object itself, but also the insights that it can give us when it is linked to other data, because that becomes really important. When we make decisions in technology, are there biases that may sway the health, that is the care that is provided, and by whom? Like, are there biases in who's deciding what care is given? And I actually don't think that this is a question of whether tech itself is neutral or not, because I don't think the answer is that tech is neutral. But I think it's more about thinking around decision-making that goes into who's designing this tech and who's using that tech, something that's been beautifully illustrated in the previous talks. And so I have quite a few thoughts on this, which I hope will come together in these few minutes. But in thinking about some of these issues, we could consider how the structure of society influences how tech is built, because tech depends on somebody responding to a problem, and this needs data to then design the response and develop that solution, right? But with that comes also issues around power imbalances. And this is illustrated beautifully, if not sadly, by Criada Perez's book, Invisible Women, where she highlights how exclusion of women led to disastrous impacts in care, in safety, and we still actually see this in clinical trials. Yet I can't help but think, for example, as a woman, a migrant, a Black African, how many of the tech in the world is designed without some of my characteristics in mind. And this makes me wonder and worry actually about a future of tech-mediated care, what this looks like for those people who are not represented in the data, those people who are marginalized, who can't articulate their concerns, and indeed those people who are beyond the boundaries of a Western or Northern European jurisdiction, because actually tech has no boundaries, right? So when we think about the design and the development, are we only considering a local or national perspective? Because to ignore some of these different identities and the ways people experience care and tech means that there are many people who are going to be left behind. And so one of the things that I find useful in thinking about the future of technology and care is, for which community are we designing the technology and who's going to benefit? Because we know for sure that as the future becomes more and more technological and digitized, the world as it stands currently means that not everyone is coming along for the ride, unfortunately. There's work that we're doing at the ADA looking at some of these issues, and there's a survey that came out in March of this year called the Data Divide. And in this report, we really show how many people in society are actually already excluded from using things like digital technologies that are meant to help people make sense of their health. We've heard of wearables, apps that assess your health, those that let you speak to a healthcare professional, all of these things that sometimes demand connectivity to the internet when actually not everyone even has access to the internet. And so in the context of healthcare from an institutional perspective, there are so many other issues that then come in, and these cogs in this wheel that influence who benefits and how that tech is going to be used. We've heard, some of you may have heard anyway, that draft data strategy for health and social care came out yesterday. And there are many ways in which data is talked about as something that's going to save lives and better futures, but there are also many points that are missing in how it might not actually achieve that. I'll give one example. COVID, everyone's tired of talking about COVID, but it has given us so many examples of how, technology and futures might look like for care. And I can use an example of an oxygen monitor. We know that in the pandemic, many people were asked to buy oxygen monitors or were given oxygen monitors to monitor themselves at home. But how could we be sure that the data that was actually coming from these monitors that was then used to make care decisions was accurate? And how can we then use that sort of thinking to think about ethics and regulation of care in this space? We know that many studies already showed that there was a difference in outcomes in terms of the oximeters. So people who had darker skin returned inaccurate results at a rate of like 11% compared to people who had lighter skin, whose rate of inaccurate results was about 4%. This actually changes the kind of information that is used to decide someone's care. And this can be a matter of life and death for some people, unfortunately. So as a practitioner, if you're given these technologies that are based on inaccurate data, as a nurse or a midwife, how do you then care for somebody when you potentially know that this technology was calibrated or was not calibrated actually for darker skin and could potentially cause harm in the future? Who then becomes accountable if, let's say, the code that was used to build systems like AI design or models is used on incomplete and inaccurate data? Is it going to be the NHS that becomes accountable? Is it the clinician who's using that tech? And should the clinician know the limits of the data that was used to then design the tech? So it's really complex. But this already, this is something that we're grappling with, I guess, and it's not a new issue. It's something that was raised back in the 90s when, studies were looking at the impact of certain interventions and kind of skin color and how that changes the accuracy of those interventions. And we can see that this will become an issue when we look at how AI is going to be used to detect skin conditions, for instance. And I think that this is actually an issue of justice that's influenced by missing data and the lack of consideration of whole communities. When we're thinking of technologies, then how are we embracing inclusivity? Another example really quickly is around genomics, gene therapies, and AI and the use of big data in this space. And we hear a lot about personalized medicine and pharmacogenomics as potential interventions that will come out of this. Yet when we look at who's actually participating in genetic studies, these are predominantly people of European heritage. And for the global majority, there isn't even an idea of mainstreaming genomics into routine clinical practice, because for sure, for many, clinical care just remains something that they're aspiring to. So the issue of bringing new technologies such as genomic technologies is something that might not be on the radar, or if it is, it's in very different ways to the way it's currently being used in European countries. So if 78% of participants in genomic studies are of European descent, what does that mean for the rest of the population in the world who are not represented in those studies? And if the data is used to create these technologies is only focused on one particular group, then you can see how inequalities are going to arise in that. So then this brings me to the question of how we regulate this area, right? So there's more accountability, more fairness in design and in the data that's used. And again, colleagues at ADA are working in this area of AI regulation, thinking around the ethical implications that come from digitizing or having a technology-led interaction with care systems. And it gets more complex when we start to think about who is participating in this. People sometimes are over-surveilled in one aspect of healthcare, but actually are not benefiting in terms of the results that come from that. But also we've got private players coming in, and I'm wrapping up in a minute. But we've got private players coming into the tech and care space. We've already heard of some of these examples. And so how do we protect people then from using untested and harmful systems that might come when people, maybe get into care technologies that are privately distributed or purchased? And so kind of to conclude, some of the things that I would like us to consider when we think about the future of care is how we regulate these technologies within and outside of hospital settings, how we define the boundaries at which technology is for care or for recreational well-being, and how we can compensate for those who've been misdiagnosed and harmed from these systems that are based on inaccurate data-driven systems. And despite all my kind of cautions, I still think that there is space for technology, but we still need to maintain the human aspect in the ways we use it.
Thank you so much, Mavis. I was thinking a lot as you were talking there. So I think maybe what I'll do is I'll just use your talk as a way into some kind of questions that I've been mulling over in the course of this discussion so far. So you kind of you make the point that we shouldn't think about technology at the level of the device alone, and I completely agree with that. You know, so your point is that we need to be thinking about the data that underpins the development of this device. We need to be thinking about users. And also, I think it comes through in your comments that we need to be aware of sort of wider systems or infrastructures and the way that they shape what the technologies are. So political infrastructures, legal infrastructures, economic infrastructures, and regulatory infrastructures as well. I think that came through very nicely in your talk. So this kind of leads me to the question of, given the sort of the complexity of what constitutes a technology, that sort of draws me to start questioning some of the premises of this event. So specifically, does it make sense to talk about technologies of care as a category? You know, can we, if we can't, you know, if the idea of technology is actually a massive term that points to a whole sort of assemblage of interacting forces, I think, you know, something very similar can be said about care. You know, does it make sense to consider care itself as a single entity? And it seems to me that there's this huge amount of variation that's possible beneath this umbrella of technologies of care. So I guess my first question, which maybe I'll put to Emma, is in which cases should we stress the specificities of technologies? And in which cases does it make most sense to think about sort of the commonalities? Where do we think about things kind of just as sort of unique instances? And where do we try to pull together this kind of categorical thinking, do you think? That's a tough question, I know, but I think maybe it speaks to what was in your talk a little bit.
It's a great question, thanks, because I think it really touches on the kind of ambiguities or the difficulties of the term technologies of care. And I think we saw also in the presentation from Stephanie and Julian that they're actually the thinking of technologies is a much broader thinking. And I was immediately actually prompted to think about the ends of care as opposed to the means of care, and there particularly how, I mean, I was stressing sort of cost cutting and sort of making everybody available for the labour market. Those are the kind of two driving forces of a lot of technology at the moment, thinking as instances and individual units. But I think the ends of care also not perhaps as the kind of the individual isolated subject that has to conform to an idealized notion of optimal care, which actually nobody in reality corresponds to anyway at any time, and given there are variations in degrees, etc. But I think this is the sort of question of interdependence and codependence and the possibilities of collective living across different areas of our lives. There, I think there's a question about how do we think of technologies of care integrated along the lines of what the ends of care should be. And then, of course, within that, we have the question of what are the specific technologies in terms of devices that are then also open to a whole array of questions of what ends is care serving for whom. And so then we come back to questions of business models, profitability, privatization, and then also the sort of the backs of the care workers and care recipients on whom these devices are perhaps, you know, in exclusionary ways being developed, or not in consideration of whom these devices are not being developed. So that's kind of like a roundabout way of answering to your question that do we need other terminology perhaps, or do we need a sort of differentiating terminology? But how do we actually think about these broader sort of ends of care, the broader context in which these technologies of care sit, and these individual devices in terms of what, you know, out of what kinds of considerations that care is supposed to be instrumental for, are they considered?
Yeah, I guess it sort of relates to the issue of who we talk about when we talk about carers as well, because I think to some extent that's always a political move. You know, when we're discussing care and we're discussing who counts as a care worker, in some instances you want to be getting into the very specific conditions in which people are working. You know, you want to be talking, you want to be engaging with concrete conditions on the ground, which can sort of mean focus on very particular groups of people. But then there are this other political dimension where maybe perhaps we're thinking in terms of solidarity, or we're thinking in terms of building political power, where it can be useful to draw people in under the same category. So I think always it's a very necessarily sort of situated and context dependent discussion, where you're always thinking, okay, well, why am I talking about care? What does it mean to draw people together or disentangle them? What are the sort of affordances of doing that? And I guess kind of trying to keep that in mind, that there isn't, we're always assembling the subject of which we seem merely to speak, if you know what I mean. And I guess it seems to me that one crucial idea that emerges in everybody's work who participated in the event today is that the ways technology of care, if we're going to continue to use that shorthand, are used and experienced, will be shaped by the conditions of their emergence. So how technologies have been designed and with which affordances in mind will determine how they impact care workers and those in receipt of care. So I'm going to put this question to Mavis, if I will, as it seems to relate to some of the things and the themes that were coming through in your presentation. Under what conditions are technologies most likely to benefit those who use them? You know, are there certain models of funding, design, access, or ownership which have more emancipatory potential than others? So, you know, things like transparency and algorithmic decision making, for example. You know, this is sort of a principle that I know some are sort of advancing as a way of trying to deal with or confront the difficulties of the increasing encroachment of AI into health and care spaces. And maybe what are the factors driving the development of caring technologies today? You know, how can we intervene within them? Anything in that ballpark would be brilliant. Maybe.
I like these questions. They're not easy at all. I think like people's personal experience usually tends to be one of the ways in which we can make technologies work for people, right? So if it's people sitting in a you know, office somewhere thinking, oh, wouldn't it be great if we could monitor people's, you know, blood pressure from you know, remotely? Why? It's always asking, well, why would we want to do that? What are we really trying to kind of replace? And I worry that a lot of the things that tend to then get replaced are these human interactions, the things that actually will make someone make sense of their environment and their life experiences, and especially of kind of the condition that they may or may not have. Because a lot of health is actually relational, right? So just saying someone has high blood pressure, but not thinking about, do they have housing? Do they have access to food? Are technologists thinking about these extra issues, and are they able to, you know, find a way to bring that into the design? Because if they're not, then those technologies won't work. And you talk about transparency. I think it's great. Like a lot of the kind of upcoming issues around ethical AI and design have started from grassroots level. People have gone, well, hold on, this doesn't work for me. And there's somebody called Joy Polwamini, and there's a thing on Netflix, a project that she did looking at over surveillance of Black people, and how being Black meant that you're over surveilled because for some reason AI kind of just assumed you're Black, so you look like everyone else. So you got over surveilled, but actually you were not benefiting from that. And you know, the facial recognition technology was misrepresenting people with dark skin. And it was from that experience that legislation then came in America around what facial recognition technology can look like. And I think there's a way in which communities can come together and say, well, what are the things that impact us in a community and the health of the community rather than of the individual, which I think was Stephanie who mentioned that. Once you start to look at community health as the collective, then people can actually decide which technologies are going to work for them rather than this top-down view.
Yeah, fantastic. I mean, so I guess one thing that's coming through quite clearly in that answer is that we need to think about the who as well as the what when it comes to technologies of care. So for whose benefit are technologies designed, you know?
Yeah, and the why, for sure, like who's funding these, right? Who's funding the technologies? Because I think you'll start to see, like Emma was saying, when you look at GP at Hand in Babylon, there are these, imbalances in the ways in which funding happens and who then benefits downstream. So those are very important questions.
Yeah, I mean, so I think maybe this brings in a question about who the perceived consumer is as well. So and why that matters. So so one sort of just to take maybe one example. So things like monitoring services for the elderly, for example. Who is the perceived consumer of those technologies? They're typically pitched, I think, at the adult children of older people, who might be concerned about their parents' well-being. They might be looking for remote solutions if they can't be there physically. They want to ensure that their elderly parents are safe and so on. But that then raises these questions about how risk and freedom are to be balanced with and through these technologies, because I think that's going to be skewed by the envisaged need of the consumer. And if that consumer is not the person who's being monitored, then the emphasis may not be on things like sort of autonomy and self-determination, but rather on the avoidance of risk. That becomes the sort of the primary focus of why these technologies exist. So maybe I'll put this question to Julian and Steph. I hope you don't mind me treating you as a unit, given that you co-presented. How can people act to ensure that technologies of care do not feel limiting and intrusive, but actually that technologies of care are being put to this use for maximizing autonomy?
Steph, do you want to, I'll try. Okay. The only answer that I think I can give, and also sort of through some of the work and some of the thinking that we've been doing, has been sort of about collective subjects versus individual subjects, and how decisions and desires and I guess, how decisions and desires are formulated differently when people sort of negotiate them in group. I would say that is really the key. I don't know if Stephanie wants to add something.
No, I'll build on what you're saying. I think to positive effect and negative effect, right? Like we see that if you're, that groups can quell sensibilities that individuals want to express, but they can also bring things out that one wouldn't have otherwise expressed a need for or desire for. And I think as we've been thinking about this work, it's really about the opportunities for mediation, of course, to participate in the broader systems in which it exists, but how can these kind of collective arrangements open up mediation, like mediation as, can we use that as a positive and co-constructive thing, rather than a thing that is modeled around substitution or something like this. So I've been just in this conversation, I've been thinking about things that we wouldn't maybe call technologies today that are clearly technologies, a bed that raises and lowers itself, right? And if two people are in that bed, then there's a whole other negotiation that needs to happen around the positionality than one person, or maybe you can, are you allowed to independently organize it? If two are in there, does it have to go together? And all of these kinds of really specific granular decisions in some ways shape what the arrangements are between individual bodies and collective bodies. I mean, this is a silly little example, but I think it's like, to us, this moving bed didn't replace a worker necessarily. We hope that it opened up opportunities for care workers in other domains to have more affective engagements, because we know there's this huge missing element of care, right? From all the needs we have to be cared and cared for across, and cared for other things across society. And so that's part of what we're trying to navigate.
Yeah, I mean, I think there are hugely rich philosophical questions kind of running through this about what autonomy means at an individual level versus a collective level, which I think are really fascinating. And it sort of just triggers for me, like, a lot of what we've been emphasizing here is the ideas of, excuse me, like transparency and choice and being able to understand things. But just listening to you talk, like, part of it is about, to what extent do we really want to understand these things inside and out? To what extent do we just want to be able to trust? You know, do we really want to have to sit down and understand the black boxing of these technologies and really understand how the algorithm works? That puts a huge sort of like burden of understanding on somebody who probably just wants to engage with a system that works and that they can trust. You know, so to some extent, autonomy isn't necessarily just about kind of getting in, you know, understanding things in comprehensive detail. It might be about not feeling that burden of understanding things in detail and be able just to sort of to just live without dealing with it. Like this idea of the automatic and the autonomous being kind of related things. You know, I think that's quite an interesting question. I mean, maybe I'll just build on some of these discussions about the consumer that was kind of lurking in the background, and maybe I'll ask this question to you, Dennis. So thinking about technologies of care as kind of commercial products and thinking about kind of the implications of this, how are technologies of care and their users being represented in popular and promotional culture? You know, does this vary by audience? And if so, how? And does it matter how technologies are framed or depicted? You know, and if so, is this an area where you think maybe academics or activists or other kind of stakeholders might try to intervene in some way?
I think that's a very important question. In particular, depiction, if we're looking at any kind of media outlet, like the little article that I showed from the BBC, whether your toaster can help you care for your mother better. This is actually what does shape the perception of a lot of people who might make decisions for what technology to adopt for care. So that might be people who are buying it in for care providers, but it might also be families of people who are going into care, how open-minded they are towards new changes, trying to do something. There's a really interesting question in the chat as well that goes into the thing, is the technology actually developed to just kind of paper over the cracks of the care system? Or does it actually bring something to the table that is, like you said, Helen, something that's trustworthy, something that's actually helping? So I think when you look at the media representation in particular, there's a lot of myth busting required. Technologies are often presented as taking away jobs, replacing human interaction, and something that we all should be wary about. However, a lot of technologies of care that we are seeing have actually the potential to also enhance the human dimension of care work when it comes to it. So take, for example, what Emma said as an example in her talk, an automated monitoring system that supports keeping track of the care provider for a person. Now, if you look at it from a business saving point of view, of a cost saving point of view, you might say this frees up the time for someone to take on more care, people in care to look after them. But it could also free up the time because it cuts down admin paperwork and could free up the time for carers to interact more and connect more with the person that is in care. So I think a fairer depiction of technologies of care would probably be as something that enables care work in the future rather than taking it over. And this public image would definitely help with technology adoption. So the public would develop a more open mind towards technologies of care. So the aide-memoire case study that I talked about is a very good example where without a human facilitator, this app wouldn't work. It's nothing that can replace anything else. It might enhance what's already out there, and it can enhance the quality of the time that you're spending with people. Another thing that I see a lot in media depiction as well is that the media keeps picking up on that society seems to be worried about surveillance. So in that article from the BBC, there was actually in the first 2 sentences, this was something the article already addressed, the fear of misuse of the technology, and how the toaster could give away private data about your mother or your father. And this is, I mean, I don't want to get lost into how much data we are sharing anyway already. Is the toaster data really the one that you should be worried about? But it goes about the idea that people don't like to be tracked, measured, and surveyed. And the media often jumps on this aspect. I think here again, a more nuanced storytelling is actually needed to have this kind of a balance sheet of advantages, what kind of use you can actually have of this, and what data you are actually sharing, what people can do with it. I also think that there's an obligation from universities to help here to inform the public, including the media, to understand and form the perception better. And this is particularly around the ethical component when it comes to technology, to really look into what new technologies of care could mean when they are implemented in real life, and how this could impact whether it is the data sharing that Mavis was talking about, or whether it is the fact that you just want to make sure where the data actually goes and how this can be used in the future.
Brilliant. Okay, I think it's very helpful that you've mentioned universities there. So what I'm going to do, I'm going to ask all of our participants one final question. Whilst I'm doing that, I would invite our audience to articulate any questions that you might have. Erica, I know, is gathering them together to share with us. So I'll ask this one last question whilst our audience does their final mulling. And so I sort of preface this event by saying that I'm really interested in the future direction. So what we as sort of policy researchers or academic researchers can contribute to steering technologies of care in a more emancipatory direction. So my question for everybody would be, what do you consider to be among the most important next steps for research in this area? What role can academic or para-academic research play in steering the design and development of technologies of care in an emancipatory direction? And is that even an appropriate way of framing our ambitions here? So maybe if we just go in order of the speaking order, and we start with Emma here. Oh, Emma, you're muted.
Thank you. I still do it, even though, after a year and a half. I think one of the really important issues here, and I think it's coming up in the chat as well, in terms of other technologies that need to be resisted as opposed to technologies that need to be merely reformed or repurposed. And I think that to have the breadth of that debate, I think, is really important, and also that sometimes technology should also be resisted. But I think to keep it short, one of the really important aspects, I think, is the low value attributed to social care entails its false characterization as unskilled work. And I think that is really an important aspect as well, that actually when we think about what care work is, it's something much more complex than is often portrayed. And I think that really needs to be a part of what we're thinking about. And there are sort of quick fix solutions are not suited. And also that, and again, this has come up in the chat, that when we're thinking like research about technology, is that it's not the technology itself that's going to fix the crisis in care that we have, and what role there is for technology is also different ownership models around technology, the involvement of care workers and care users in those is really important. But the technology itself is not the fix, and taking a step back from that, I think, is a really important aspect in terms of future research.
Yeah, I think that's a great point about the fact that it's not, we can't assume that all technologies are reformable. Actually saying no is really important. And I think that kind of came through a little bit in some of the stuff that Mavis was saying about surveillance and facial recognition systems. There's been a lot of really strong work about actually you can't, we're not kind of arguing for let's have better facial recognition so that people of all races and genders can be surveilled equally. Actually, I think that it's about pushing against that and saying, well, let's refuse this idea that everybody has to become legible algorithmically. You know, let's kind of challenge that idea. Brilliant. Okay, so let's move on to Dennis. You've already touched on this a little bit.
Yeah, and I want to echo what Emma said, that I think one of the biggest things that needs to be done is the value that's being attributed to adult social care or care work in general. There is a lot of attention, and particularly in the UK, on NHS and NHS work in hospitals and so on. But the care work is often seen as something that falls off the table a bit. And I think this is something that really is something that needs to be changed. And to add to that as well is not just formal care work in care homes, it's also family-driven care work that I think needs to be included into this discussion. And a lot of the things that were said in this panel was, who's actually the decision maker? Who's buying for this? A family will have very different motives and driving factors why they want to integrate a technology of care compared to someone who's running a business with it. And I think this brings me to the point, just what I think needs to be done next is the technologies of care need to have a benefit for all stakeholders, and that needs to be explored. So of course it needs to have a benefit for the people in care to improve the quality of care. It needs to have a benefit for the care provider. It should make sense as a business investment, whether that is as a marketing tool or to reduce costs or whatever. But it also needs to have the stakeholder that is the most neglected in the discussion, and that's the carer themselves, their benefits in terms of labor, their day-to-day care practice and what to do with this. I think it's particularly important to understand how the technology can enhance their working practice and offer a better care outcome without stretching the workforce even thinner by just piling on new things. That's what I see as being something that really needs to be tackled more heads-on in academia or in this discussion in general about technologies of care.
Yeah, I think that sort of relates back to this point about who we are designating a carer at any given time, and actually the points at which it makes sense to do this kind of work of this assembling work of bringing people together under the banner of care, you know, and what we can do when we make sure that we're not just talking about people in sort of specific silos, but integrating together this idea of the work of care that is distributed in various ways across the social fabric. Yeah, brilliant. Julian and Stephanie, I don't know if you want to speak together or separately. I will.
I'll start. Maybe Stephanie will jump in to explain what I just said. It just happens often. I think what I guess what we'd like to challenge is this idea of health being an individual issue. It's your problem. It's your fault. You know, it's whether your health is your problem or whether your mother's health is your problem again. And I guess in developing sort of these collective forms, we need to start thinking about collective interfaces, really, which to me is a really complex problem, and I guess proposition to put forward, because when we think of interface, we really automatically think of sort of our hand on one hand on one device, and actually sort of thinking about what a collective interface is really the question that I'd be asking.
Mm.
Yeah, I think just to add to all of that is questions around, I think if we take a bit of a systems thinking approach to all of this, especially with the emergence of new technologies, what kinds of collective, whether it's political economies or interfaces or capacities, we want to sort of smuggle in with the technologies that are introduced that might potentially be beneficial, but I think as we've been talking about that they're not neutral, that's also to say that there is kind of in an emergent moment to kind of shift the unit in which they're conceived, and also the arrangements around which they're deployed. And so I think we tend to take a little bit of a utopian, or as we would think, reasonable approach to that kind of thinking.
I just want to add, sorry, something that I left behind. I think when we talk about collective interfaces and collective users, we're not just talking about sort of those who are sort of more on the receiving end of care, but we're also thinking about cooperative and collective forms of delivering that care, and that we really need technologies that sort of enable that cooperative delivery of care.
Yeah, I think this is one theme that I'm very pleased has come through consistently throughout what people are talking about today, is that we're not talking about, you know, the individualization of care. We're consistently situating it within this wider network of people and forces. And I think that's so incredibly important when we're talking about technology, care, and technologies of care. Mavis.
I mean, wow, just to add really to all these important points is, I guess for me, thinking about what harms look like, I completely am for the benefits of care and technologies and the interface within that. But I also am quite cautious about assumptions that are built into technologies about it being the go-to, or it being the thing that's going to help care workers. Like, let's continue to engage people and ask them, is this something that will help you, and what, or, you know, is it something that we're anticipating but actually have no evidence of that work? And then thinking of the collective, just to broaden our outlook a little bit and see how other communities are integrating technology into their care systems and their health systems. And there's great work being done with different Indigenous communities in Australia and in Canada, looking at, you know, care principles and imagining benefit of technologies and care in communities. So I think as we kind of shift our research, let's consider how issues such as solidarity might be excluding or including different kinds of people, and how we cut up society by that, because that then helps us understand who's in and who's out in these assessments of harms and benefits.
Fantastic, thank you. Okay, Erica, I will flip over to you so you can share some of the questions, and we can use our final minutes to engage with the audience response to this event.
Thanks, Helen. Yeah, I know we're running close to the end of the time. Hopefully the attendees will be able to stick around a couple of minutes while we answer some of your questions. If not, this is being recorded, so check out Autonomy's website and Twitter, which I posted on the chat, to find out that when that gets posted. So we've had a few questions. So if we start with Emma, we've had a question on, is Ali Hoshchild's theory about emotional labour still relevant in the context of technologically mediated care? And as a comment on top of that, there was a thought of perhaps, can we expand those thinkings to think through what happens to emotions in the context of paid work oriented towards profitability, and the ways in which technologies impact on this process?
Thanks, Erica. That was my answer.
Oh, God, sorry.
So I'm sorry, I should have said, I thought it said that it was from me. I thought I wouldn't have time to answer the question, so I just thought I'd pop it in the chat. So in that sense, I guess you've already provided my answer. I do think Ali Hoshchild's questions are still relevant, and perhaps we can expand them in the context of technologies. It's in the chat.
Okay, great.
I won't take too much time.
Just too efficient, Emma.
Sorry.
Yeah, doing my job for me. Julian and Stephanie, there's a question for you. Can you expand on how you see the difference between interdependence and codependence translated into infrastructure design? And as a second question, a follow-up question, have any local authorities or bodies showed interest in creating an LTCC?
Yeah, I can pick it up. So this is something that we've had quite a bit of fun debating in the last weeks, thinking about how the ideas of different forms of dependency relate to bigger questions of autonomy. And I think for us, I mean, we think about interdependence as just part of a again, a systemic look at how the layers of space, obligation, contingency, and mediated technologies would layer onto something like an LTCC, with the idea of, I think, reducing as much as possible the kinds of codependencies that prohibit the autonomies we want. And so codependency being kinds of an extra obligation, which may be that, you know, my capacity to connect with people or care for myself is really dependent on another. And so to the degree that those can be alleviated, we're looking at how then kind of more interdependent or collective systems can be added. And I don't know if you want to clarify for me, Julian.
Yeah, I'm. No, I think I think that summed up the sort of the inter versus codependency question. I'm just going to use this little minute to talk about the question about the interest that we've received. The answer in brief is not really, but what there is interest in is, for example, Buurtzorg, which is one of the cooperative models of care that have been sort of most successful coming out of Europe at the moment. And more councils and more NHS trusts have been interested in that kind of form of care. And we've seen sort of from the literature and the research that's been coming out that these cooperative forms of care are lacking the technological infrastructure and are lacking the physical infrastructure to really be rolled out at scale. So hopefully that interest then turns into an interest into this kind of infrastructure. And you know, it is, yeah, that's, yeah, I'll stop there. Thanks.
Great, thank you. And then we've had another question, which I think I'll direct to Mavis, but please let me know if any of the other speakers have input on this. They've asked, is there any way technology can serve as a strategy to de-racialize and de-genderize care work in the sense of the embodied subjectivities that do this kind of work?
Yes, I think there's definitely space for that. Part of it, I feel like I'm saying the same thing, but it really does go back to thinking about who's taking part in the design of these technologies, and going back to sort of the communities that are impacted and getting, for example, in this instance, getting more women to take part in, you know, saying what kind of technologies they want for themselves. But there's great work with the Just AI Fellows. If you look it up, Just AI, it's part of the Nuffield Foundation, and they do amazing work in terms of the de-racialization of AI and technologies. And I think that'd be a great place to start.
Great, thank you. And then those are all the questions that came up. Apologies if I missed any. I don't think I did. We also had some great comments in the chat, especially about the users versus choosers question, and what the focus on care in the UK is at the moment. And I know, as Dennis mentioned in one of his answers in the panel as well, about the idea of reforming versus resisting technology and where those boundaries lie. So thank you to everyone who commented in as well.
Yeah, I think that question about non-reformist reforms and reformist reforms is a really important one, and where we kind of draw the boundary between these things. So understanding that I think there's a tendency to go in one of two directions when we think about technologies of care. The first is to think about sort of just sort of general shit tinkering at the edges of the system, trying to make marginal incursions to make things slightly better within systems as they stand. And then the other one is saying, well, you know, what's required is the complete techno-social overhaul of the capitalist system, which is of course true. But if there's not any sort of pathway to get there, if there's not this kind of, you've got the micro and the macro, and then there's no kind of concentration on this sort of meso-political level of how we make these interventions happen. And I think that's where this idea of non-reformist reforms is so important, and trying to establish how we can push against the boundaries of the system as it stands with a view to making life more livable for those who both deliver and receive care, with a general trajectory of a more thoroughgoing transformation. You know, it's not an easy thing to do. I mean, one of the suggestions that I've seen being made around this is that we start from the professionalization of care work. So we start from reconceiving what the value of care work is, the reconceiving of the qualities that we attribute to care, trying to carve out a space of autonomy within care as a form of employment, and start from there. But it's a very difficult question. But I think it's a horizon towards which to orient ourselves. It's starting from where we are with a view to getting elsewhere. And I really think that a lot of that has come through in the talks that we've had today and in the discussion that we've had. And I really want to pass on my sincere thanks to everybody who's here in the audience for their fantastic questions, to everybody who's been on the panel for really such stimulating and enjoyable kind of talks about a really complex and sometimes difficult subject. So I really appreciate that. And also, I would be remiss not to finish by thanking Erica for all of her organisational labour. I very much appreciate everything that you've done to steer this event into being. So thank you very much for being here. And with that, I guess we say goodbye.
Yeah, thank you very much, everyone, for joining. It's been